Hey everyone, here's part two to the pediatric and adolescent physical. Again, just like the last time, I am not going to be going over each slide in detail. It's just a quick overview, and I'll give you some tidbits of information as we move along. All right, so when we're looking at ears, we're looking at the position of the ears, how they align on the head, the tympanic membrane, and their hearing. So a gross assessment is usually done. So all newborns have a hearing test when they're done, before discharge. And if they fail it, then there has to be some sort of a follow-up. But there are certain tests that we do in the office that can assess hearing as well. They're just not as sophisticated as the ones that they get in the hospital. So let's look at the ear alignment, and we're essentially drawing a line from the outer orbit of the eye to the occiput. The pinna should meet or cross the line. So if there are any deviations in the angle or the height, we're going to look at other things. So I hate the term mental retardation. Why didn't I change that? I got this slide off of something and I should have changed that. So that's a reduction in cognitive ability. Or it can also have something to do with renal abnormalities. One of the most interesting continuing education hours I went to, or credit hour programs I went to, was a program on the physiology of the fetus and how it developed, and it was really detailed. It was all day long. It was called something else. I can't remember exactly what it was called. But that's where I learned that an ear abnormality, anytime you identify an ear abnormality, you should do an ultrasound on the kidneys just to verify that there isn't any involvement. Why? Because the kidneys are developed during the same time in utero as the ears. So if there's if you detect any issues with the ear, you may want to investigate the kidneys as well. All right, so let's look at eustachian tubes. And I like this slide because it illustrates why children are more prone to developing ear infections. Okay, so let's look at this slide. You can see that the infant's eustachian tube, which is the tube from the middle ear into the sinuses, it's horizontal, right? It doesn't drain well because of that. And it's also has a narrower angle. Now look at the adult. The adult has more of a curve to it, so it allows the fluid to drain out more easily. Why do we care about that? Okay, this is how I explain it to my patients. Children are more likely to develop ear infections because their eustachian tube is straighter and more narrow than an adult. Our body naturally produces fluid in the middle ear. When that fluid is not able to drain, it is the perfect medium for bacteria to grow and to develop and grow. And that is why children are more prone for developing ear infections when they get sick. So that's just one of the methods that I use when I'm explaining to patients about the risks or how their children develop to these maladies. So in examining the ear, you're going to find that this is different. Remember back to when you took physical assessment, all right? With the child, you want to pull down. With an adult, we're pulling up, right? But with a child, you want to pull down when you're looking inside the ear because you can see straight. You can even see in there better. This is an otoscope, and you can see it has this bulb on it. With pediatric patients, you should be using a pneumatic attachment to check to see the insufflation of the tympanic membrane. What does that mean? When you're looking in there, if you push the bulb, you should be able to see the eardrum move. It should bounce back and forth. That is a good, healthy eardrum. If it doesn't, it's not a healthy eardrum. Also, it will elicit pain in an ear infection. And here is an illustration of how some providers will examine ears in a infant, or not an infant, but a child. You can see how she's holding that otoscope differently. She's holding it up. And examining the ear is one of the things we're going to do last because kids don't like it. So when they get older, they don't mind because it tickles. It tickles in there. They kind of like that tickly feeling in your ear. But as babies, no, they hate it. When you're in there, you're going to look at the auditory canal. So you're looking at the ear canal, which is the outer ear. And you're going to look for any pre-auricular tags, cysts, or pits. And so those things can illustrate sinus tract problems. You can see in the front here. Can I use this? No, highlighter, pen, eraser, laser pointer. I'm going to use that. See if I can show you. Here. When you see here this pre-auricular skin pit, and here is a pre-auricular skin tag, this is a sinus right here. A sinus is like a pocket. Those things can become infected. And it's an abnormal connection, and it can become infected. All right, here's a beautiful picture of an eardrum, and you can see the different parts of the eardrum. This is a healthy ear here. And checking hearing. Now, this is something we're not going to routinely do on our patients, but you should know how to do it. Looking in the nose, we want to make sure that each side is patent. I take the otoscope and I look up the nose with all of my patients because I want to see the turbinates, if they're swollen. I want to see what it looks like in there. Remember, when you are examining a nose, I do it on all of my patients who are sick. I don't go up the nose. I just put it at the tip to look up. If you have sinuses that are swollen yet pale, there's an allergic component to their symptoms. If you have a patient who has swollen nasal sinuses and it's red and angry, that's more likely viral or bacterial in nature. So you're looking at the nasal septum, mucosa, sinus tenderness, and any drainage. You also are looking for to see if there's any polyps up there, and the symmetry. Here's some things that you're looking for in the nose. This is what I was talking about. When you look up there, that you can see these turbinates. Turbinates are folds of tissue, and they swell up, and that's one of the things that causes congestion. Oh, I thought, gosh, another picture. Well, here we go. Mucosal lining. I'm looking at it for color, discharge, patency, and polyps, the turbinates, and I'm looking to see if the septum is midline. You can see right here, this woman here, she has a deviated septum. And here's what it looked like if we cut her nose off. So it's over to the side. People with deviated septums are more likely to develop sinus infections. The same thing if you've had a previous sinus surgery. And here's a picture of a little child. The frontal sinuses develop around age 8, but not fully aerated until adolescence. The ethmoid sinuses, the ones up here, developed at birth, aerated at 4 months. Maxillary, aerated at 4 months. Sphenoid, where's the sphenoid? Number 4, here we go. Those are developed around age 3 to 4, aeration between 7 and 8. So no air goes through them until that's what aeration means. Mouth and the throat, we're looking at the lips, buccal mucosa, tongue, teeth, palate, tonsils, posterior pharynx, and gag reflex. And I have had to look at a lot of these because I've seen a lot of hand, foot, and mouth disease over the last month, and a ton this time of year. People just don't realize that when you get sick, you get a sore throat, you get a runny nose and congestion, and it might last 2 weeks. They all come in after having symptoms for 2 days because they think they have strep throat. No, they don't have strep throat. They're just miserable. And so then they come in and we do a strep test. It's negative, and I don't give anybody antibiotics unless I think that it's warranted because of antibiotic stewardship. And here's a good picture of the mouth and throat and what I'm looking at. This person has tonsils here, And I've had a couple of patients the last month that had inflamed. Why can't I think of the name of it? Uvula. A really swollen uvula where I've had to give them steroids. It wasn't occluding their airway or anything, but it was really large. All right, with the little kiddos, we're going to look for when their teeth start coming out. They usually get 20 teeth between 6 and 24 months, and they get really cranky when they're getting teeth. But teething does not make them sick. So sometimes parents will say, oh, she's teething, that's why she's sick. No, she's sick. It can make them have pain, and you give them Tylenol, it makes them feel better, but it doesn't make them have runny nose, congestion, and cough. And here we go. Permanent teeth begin forming in the jaw by 6 months of age. And it's really important to do things like no bed bottles and things like that, because you can actually decay their permanent teeth before they ever erupt. And here we're looking for malocclusion. And we're looking to observe the gingiva and buccal mucosa for color, texture, and moistness. We're looking at the tongue, and can they extend it? You can see this little kid here has a tongue tag down here. They used to call this tongue tied back in the day, and I have had physicians who actually just snipped it right there. But now I've heard more and more the process is to just leave it alone, that it doesn't interfere with anything. So here's some example of Kotlow diagnosis for tongue-tied in infants. Maybe it's dependent on the severity of it. The neck, we're looking at the trachea. For deviation, it should be midline. Palpate the thyroid, assess for nuchal rigidity. I had a older person a month ago, came in with fever and sore throat. All tests were negative. He could not move his head. He couldn't move his head. I sent him to the emergency room. And one of the things that's unfortunate is I don't know what happened. I don't know, but I was suspecting meningitis with him. The most common meningitis is viral meningitis, and it runs its course. It's less lethal, but does require hospitalization in most cases because of the severe pain, headache pain, and that's what this kid had. Looking for lymph nodes, here's where you're going to look for them. And congenital muscular torticollis, it's damage to the sternocleidomastoid muscle, birth trauma, or intrauterine malposition. And so this needs, these kids have to go to physical therapy. So when we're doing a physical assessment, we're looking at these body systems. Remember, there are 13 different body systems that we're evaluating with every patient. And here's the chest, or we're listening for the heart, of course, for rhythm and all of those things. With the younger population, it's very important to listen for arrhythmias. Some of them are not detected until later in life. I was doing a sports physical on a kid the other day, detected a murmur. No one had ever detected it before. In all likelihood, this was not a new murmur. It doesn't typically happen as they get older. They're born with it. So we're looking at the chest. The movement, do both sides move symmetrically, the rate, rhythm, depth, and here's a little app site you can go to listen to breath sounds. The ribs, we're looking to see how the ribs are aligned. We're looking for barrel chests, and that's particularly in patients with chronic asthma disease, cystic fibrosis, asthma, things like that. And pectus excavatum, pectus carniticum are different variations that you're going to see in the sternum. And here's what it's illustrated for. Severe pectus excavatum, like this picture, can require cervical correction. I've had 2 patients that I'm aware of that had surgery. And they said it was excruciatingly painful to get it repaired. One, it was successful. The other one, it popped back in. and he said he would not have it done again. It was that painful. When someone has this, you also, and if you have to look for other signs, they, what you want to make sure, you want to rule out Marfan syndromes in these kids. And here's an example of pigeon chest or pectus carinatum. So with developmental differences in children, you can see retractions. Look for them in these areas. Okay, I had a child the other day coming in with retractions. I mean, this one was about, I think 2 or under. Definitely having retractions with that cough. The kid was definitely croupy, so I gave her a dose of steroid and a nebulizer treatment, and she was good to go. Wonderfully, she had nebulizer at home, so I sent her home on nebulizers every 4 to 6 and steroids. Here are the different lobes of the lung and how you can access them or assess them in children and pediatric patients. Let's look at the cardiac area. And when you're listening to the heart, I always think that they think I'm crazy because I start listening up here. So I listen here, and then here, and then here, 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 and I actually listen over here as well. I'm waiting for someone to say to me, you know, the heart's on the other side, but they never have. So here are some heart sounds, and here's a great little site you can go to listen to different arrhythmias. You really, now that you're going to be professionals, you're going to be providers, you have to have a really good stethoscope. That is really important. If you're going to invest money in anything, invest in a good stethoscope. All right, here is different areas of VSD where you're going to hear it most likely. Vasculature, you're going to look for cap refill, pulses, distended neck veins, those things you typically would look for in a bigger adult. You're just looking for them in a little adult, or not a little adult, a child. Here's the different pulse locations. And here's how you feel them. These are not kids, but this is, I think you know how to do that. We want to palpate femoral pulses in infants. If you see weak or absent, it could indicate coarctation of the aorta. So we need to definitely do an echo on those kids. Let's look at the abdomen. Just like an adult, inspect, auscultate, palpate, percuss. Inspect, look for the size of the abdomen. Remember, infants have that abdomen that sticks out because of their scaphoid. Umbilicus, looking for hernias. Auscultate for bowel sounds. Whenever a kid comes in with abdominal pain, I always want to rule out appendicitis. GU, inspect external genitalia. We don't do exams on the pelvis or rectums. If we're worried about something like that, they're going to go to a specialist. But I do look for hydrocele, and I am going to look to make sure that their testes are descended. I'm looking to make sure that their meatus is central. And I'm doing Tanner staging in adolescents, both boys and girls. So here is how we palpate the scrotum. And this is a little girl looking for normal. This is a normal infant female external genitalia. It's normal for females to have some thick white discharge. They also may have some spots of blood. It's their first little period. It's a pseudomenses. That is due to hormones that their mother's hormones that are in their body. And this is normal male external genitalia. Now here, see what I was talking about looking at the urethral meatus, hypospadias. You can see that the, where's my little thing here? That the urethra, or the opening to the urethra, is not, the urinary meatus is not central. It should be here, right? It's here. But it can be all the way down here, and that needs to be surgically repaired. Look for hernias and hydrocele. And we're going to look, palpate the scrotal testes. Newborns, it's not terribly uncommon for their testes to be not undescended. They will make their way down most of the time. Sometimes they have to be surgically brought down. Tanner stages. So as when kids get older, it's important to document this. Now, there's a big difference between a sports physical and an annual physical. Sports physicals, we don't care about this stuff. We are essentially checking to make sure that they're neurologically intact and their muscles all work and they have good vision, okay? With a Tanner score, that's when we're going to do that annual big physical where we're checking everything. And here's some more on the Tanner. Musculoskeletal. Look for inspection, function, and gait. So we're looking at the extremities for alignment, contour, size. We're looking for gross deformities. Looking at the skin, subcutaneous tissue over the muscles and joints. Any skin fold should be symmetrical, and I'm checking for swelling and masses. I'm looking for muscles to compare them to ensure that they are the same size, that they're symmetrical, and that there aren't any spasms present. I'm palpating the bones for muscle tone. Is there heat, tenderness, swelling, or crepitus? Can I feel crepitus? Feels like you're taking wrapping paper and scrunching it up. That's what it feels like when you put your hand on the joint and you move it. Test each major joint for active and passive range of motion. And joints that deserve particular attention. Now, I got to tell you, typically, this is not something that is done routinely during an annual physical. This stuff is done. I check joints during my sports exams, but I do it differently. I'm not touching each joint and feeling it. That physical would take 2 hours. There are different things that I do, so I'm very interested to hear what your provider does to evaluate those things. Now, in an infant, absolutely. I am checking all of that stuff. But in a 15-year-old that's coming in because he wants to play baseball and he has a negative health history, no, I'm not typically checking all of those things. In infants, we're looking for posture, movements, hair tufts and dimples, any cyst near the spine, and any curvature. Spina bifida, and there's a video here. It's an osmosis video. Love osmosis on spina bifida. And here we have the different types. And there are 3 types of spina bifida. More information on it. Now, neural tube defects can be detected early on due to the examination of the maternal alpha-fetoprotein. It doesn't detect all of them, but it detects a great deal. And for infants, again, we're checking extremities and palpating bones, the spine, muscles, and joints, motor development. This is the Barlow test and Ortolani test. And we do this, we're checking to look, this test, we're looking for hip dislocation. And this is how you do the process. It's very simple, but we do it on all the infants. I do it when they're first born, and then I'll do it when they're in the office too. Once they get to be a couple months old, I don't do it anymore. More on this one. And here's a video that illustrates the demonstration of it. Gilazzi test, looking for differences in knee height. And children, these are other things we're looking for. Again, we're looking for bow legs, knock knees, room between the legs. And here is the physiologic evolution of the leg alignment. And you can look at the different years and ages. So all newborns have legs look like that. That's normal for them. It wouldn't be normal for an adolescent. And here's a way to assess those knees for more accurate measurement. Now, they're only going to do this if they detect something, okay, if something looks abnormal. Knock knees, more common between the ages of 2 and 4. Feet, all infants, they have flat feet. And they will develop as they get older, that arch. I love baby feet. Here's an example of a club foot. I have had a patient that was born with a club foot. It was surgically repaired. Hands, normal hands, and then you've got the semi-increase, which is more common in infants that have Down syndrome. Adolescents, we're going to do the same examination as we would for an adult. The big differences, we're looking for scoliosis and note for slight kyphosis or rounded shoulders. And we don't look for these in adults because the curvature is going to stop once they stop growing. And really, there isn't anything we're going to do for an adult that may have a slight curvature. And I know this because my oldest daughter, she's in her 40s now. It wasn't detected that she had a curvature until she was, oh my gosh, I want to say an adolescent. I switched pediatricians because my pediatrician retired, and they said, oh, she's got scoliosis. Oh, so I took her to a pediatric orthopedist. And they said, no, she has stopped growing, so there's no need to worry about it. And females typically stop growing once they have the onset of their menses. So just food for thought with that one. And here is what scoliosis looks like on an examination. Here's a normal spine, and here's the deformity of scoliosis. Now, I have lots of patients, and my daughter's, for example, it is not this margin. Okay, this is quite a striking margin. Hers is much less, but you do want to look at this for every child that you do an exam on. Neurologic exam, the same as for adult. If you're over the age of 2, you're looking for motor, sensory, cerebellar function, and cranial nerves, reflexes, and behavior. Neuro, observed behaviors, mood, affect, interaction with the environment. Spontaneous activity and purposeful movement begins early, about 2 months of age. They start grabbing for stuff. And then it becomes grabbing objects with the hand, transferring objects, purposely releasing. Looking at the developmental standards is incredibly important. So I strongly encourage you to grasp that. In fact, I'm going to see if I can find some better resources for you to check the developmental stages of your patients. It's very important. Reflexes in the infant, rooting. Here's a couple of reflexes. I'm not going to go over all of them. These are all reflexes in the infant. And those they don't last long, though. They're born with them, but they don't last long. There's some purpose to them. I don't know what, though. All right, and here's our references. So I certainly hope that this presentation was helpful for you. This one was a little shorter than the last one, but make sure that go into your practicums with a good understanding of the information that we've discussed in these 2 lectures. It will definitely benefit you.